Before I start, I'm only going to take about 5 to 10 minutes, partly because I just don't have that much to say. Gilly said a lot of it already. I just want to provide a brief update about what the European Haematology Association is up to in relation to the MCBS. And also I want to, we've got a slight change to the agenda coming up as well, in that we're including an additional speaker that's not listed at the moment. So we will be having Patrick Bonnet from AbbVie is going to do an additional talk after Natalie's talk. So there's a bit more space there. All I really wanted to do was just give you an overview of where the coalition is involved in some of the work that Gilly's just been talking to you about. So there's sort of two main links that we have with the work that's being done on the MCBS to make it fit or be more appropriate for haematology. One is via the Harmony Big Data project, which is a huge pan-European big data for better outcomes innovative medicines initiative approach. It's a massive project. I'm not quite sure how effective it is ultimately being, but it works over 5 years, has over 50 partners, both from the public side of life and also from the industry side. And it's trying to really collate lots of trial data, research data that then can be analysed from a big data perspective to see what it's telling us about outcomes in different haematological diseases. We're one of the patient organisations that are involved in that. Natasha and I attend those meetings and try and participate. As part of that, EHA is doing some work around adapting the MCBS from ESMO to fit for haematology. Technically, it's not really a formal part of Harmony, but it's being brought into it because it's so relevant. We're also involved with EHA's work generally through we've very recently acquired a place on the European Affairs Committee, and we're one of 3 patient representatives on that. And the committee is one part of EHA that's looking at the revisions to the MCBS. So I've got lots of slides here. I'm not going to go through them all. What I did think would be helpful is really just to give you an overview of our understanding of what EHA's up to and what they've said so far. I thought I might talk to Gilly about this as well, just to show you some of the forms for the MCBS, because it's just more illustrative in some respects to see what it looks like on paper, so to speak. So I'm not going to go through a lot of this because you've heard it all from Gilly. I'll just highlight this is one thing that EHA is doing in terms of their tests and process. So they've looked at lymphomas last year. They've got field testing on the haematology version of the MCBS in these different blood cancer subtypes, so ALL, AML, CLL, MDS, multiple myeloma, and they're going to look at chronic myeloid leukemia at some point in the future. The key opinion leaders from each of those blood cancer types met in March to look at where they'd got to. And our understanding is, I checked with EHA last week about this, that there's a draft results paper is currently in the process of being written, and a white paper will be published in the next 2 or 3 months, possibly by September. And they want to have consultation involvement of stakeholders, including patient organisation groups and us, Lymphoma Coalition Europe, as to what their conclusions, their recommendations, their findings are. So that's quite an important thing for us, as you would have heard from Gilly, and we want to be more actively involved through just directly ourselves, but through the European Affairs Committee and also through the Harmony project. So you've seen all these things before in different ways. But this is going back to what Gilly was talking to you about. You have basically, essentially, a set of different forms for the different settings and the different situations that you will find yourself in assessing treatments. And so Gilly mentioned the distinction between curative and non-curative. And I guess there's, for curative therapies, this is essentially the grading structure that someone goes through, don't they, to assess and tick the boxes as to what the research data says about the treatment. And it's as simple as that, really, isn't it? It's just they go through, tick the right box or put a grade in it appropriately, and come up with a conclusion. So it is very technical behind it, and there's lots of thought in terms of the process. But once the decisions have been made, I suppose, about what the framework is, the application is relatively straightforward, isn't it? And that's why Gilly is saying you could go off and do this yourself if if you've got a good enough understanding of the clinical trial data or the summary of it. You can actually, and your own perspective, the patient organisation perspective, you could have a go at making your own assessment and see if it fits with what the clinicians have come up with. And like Gilly says, because we've all got our own different value frameworks, it will likely be slightly different, and then that gives us a case to argue from. So there probably is a case for us as a coalition to think about, like Gilly said, do we sit down, spend some time one day or a couple of days going through some of the new treatments that have either just come through or are coming through and see what we think of them and build our own cases. So, and again, there's another one for the different primary endpoint there. So it's but it does the same sorts of things with grading systems. So I'm not going to get I've got loads of slides like this, and I could bore you to death with forms if I was a bureaucrat, but I'm not going to. But essentially, this is an example here where there's an evaluation goes on. It's either going to be 1, 2, or 3, or 4, because that's as far as they will go. But then, as Gilly was saying, there's a caveat where they will upgrade it or move it up one up the scale because of certain qualities or factors. And I think we will share these slides with you all later, so you can go through them at your leisure, if that's the bag you're into. But just going back to what EHA's been doing, these are the summary that were presented at the Harmony, at the Harmony project around their conclusions. So the ESMO MCBS assigned grades to the treatment studies analysed that are in line with the benefit currently associated in clinical practice, especially in AML, lymphomas, and multiple myeloma. We haven't seen the evidence or the summary of what that was, or what they will come out in the results paper. So we just have to take that at face value. So they're saying that what was in the ESMO scale currently matches, is not too far off with what you'd expect to see in haematology. They did, however, say that in specific cases, surrogate endpoints could be considered, for example, complete remission rate at 24 months for follicular lymphoma. And I would expect that's probably right. We know that's a chronic disease. There's a different set of circumstances that you would want assessed or measured in any clinical assessment or patient organisation assessment. To evaluate chronic diseases treatment studies, the scale should be updated, including surrogate endpoints currently used, like minimal residual disease, and considering different cutoffs for mature data because of the long survivals expected in these settings. And I'm sure most of us that are involved in the chronic subtypes of lymphoma would agree with that. It's, that's probably where the ESMO scale isn't going to quite work properly and does need quite significant adaptation. Single-arm studies in haematology could require the development of a different evaluation form when long tails are present in the overall survival analyses. And again, you would expect that's right, and that's going to be a particular issue in many rare diseases. But given the range and difference and complexity of the subtypes in lymphoma, you're going to have lots of small studies, single-arm studies as well, so that has to be followed up. In studies of MDS therapies that are not likely to be curative with a primary endpoint other than overall survival or progression-free survival, response can be measured looking at different parameters. And the scale should differentiate these different types of responses measured to reflect the real clinical benefit. So, again, another one of their conclusions, and I think this is the last one. In some haematology areas, the distinction between curable versus non-curable could be better defined as intensive treatment versus non-intensive treatment. So that's another area that they're looking at. And so that's what they've said, that's what they're saying publicly about the conclusions they've drawn so far. I guess they're writing these results up and analysis up, and we'll see a lot more detail about what that means in practice and the evidence or the assessments that they carried out to come to these conclusions. Oh, sorry, there's a sixth one. Since toxicities in haematological diseases trials often include measurements that do not directly result in clinical signs and symptoms, score corrections are applied only when clinical meaningful toxicities are detected. I thought there were only 5, but yeah, so that makes sense, doesn't it, really? So that's all I think I need to cover. It's just to give you a sense of what Lymphoma Coalition Europe is doing and how it's involved. Happy to take any questions, but I don't, in terms of the detail of what EHA's up to, I don't know any more than that because that's all they're willing to disclose at the moment. We're hoping that by the end of the summer we'll see a lot more and we'll be able to participate much more directly, and certainly we'll share that with all the member organisations.